There is something happening inside doctors' offices across this country that almost nobody is talking about. And if you are over 65, it could be affecting your health in ways that have nothing to do with the illness your doctor is supposedly looking for. Most people over 65 walk into their annual checkup trusting that every test on that order sheet is there for a reason, that someone, somewhere, carefully decided those screenings are the best thing for a person at their age with their history. But what if that assumption has been quietly wrong for years? What if some of those tests, the ones you never questioned, the ones that feel routine and responsible, are actually creating health problems that would never have existed if you had simply stayed home? I am not talking about skipping care. I am not telling you to stop seeing your doctor. I am telling you that after 65, the science on certain screenings shifts in a way that most patients are never told about, and the gap between what the guidelines say and what actually gets ordered is wider than you would ever imagine. My name is Dr. Hargrove, and I have spent the last 2 decades working with adults in their 60s, 70s, and 80s, and the single most consistent thing I have seen is this: well-meaning, health-conscious people getting swept into a cascade of testing and treatment that started from a test they did not need, that found something that was never going to hurt them, and that launched them into a medical journey filled with anxiety, side effects, and in some cases, genuine physical harm. Today, I am going to walk you through 5 specific screenings where that story plays out again and again, and I am going to give you the exact words to use at your next appointment so that you are the one driving the conversation, instead of sitting there nodding and wondering if you should have asked more questions. Let me start with something that is going to surprise you, because most people over 65 have never once been told this particular piece of information, and they absolutely should have been. Routine colonoscopy after the age of 75, for adults with a long history of clean results and no family history of colon cancer, is no longer recommended by the leading preventive medicine guidelines in this country. Read that sentence again, not because it is shocking, because it matters. The U.S. Preventive Services Task Force, which is the body that sets the standard for exactly this kind of guidance, is clear on this point. For adults over 75 with consistently normal prior results, the risks of the procedure begin to outweigh the benefits. And the risks are real, and they are specific. Colonoscopy requires full sedation. After 70, that sedation carries a statistically higher risk of post-procedure confusion, respiratory complications, and falls in the days that follow. The procedure itself carries a risk of bowel perforation, and that risk increases with age because the tissue in the colon wall becomes more fragile over time. A perforation at 78 is not the same recovery as a perforation at 50. It is a genuinely dangerous complication. What do thoughtful physicians do with older patients at this point in their care? Many quietly switch to a stool-based test, something the patient can do at home with no preparation, no sedation, no recovery day, and no risk of perforation. It gives clinically useful information with a fraction of the risk. The problem is that no one explains the shift to the patient. The test just changes on the order sheet, and the patient never knows why. If you are over 75 and your results have been clean your whole life, before you schedule another colonoscopy, ask your doctor plainly whether a less invasive option would give the same protection without the procedural risk. That one question could save you from a dangerous procedure you never needed in the first place. Now let me take you to a story that captures what I am talking about better than any statistic can. A man I will call Gerald, 73, a retired high school principal from outside of Nashville, came to me after what should have been a simple annual physical turned into something that changed his life. He had no symptoms. His blood pressure was controlled. He exercised regularly and felt strong. His doctor ordered a routine cardiac stress test at his annual visit. Not because Gerald had complained of anything, not because there was a clinical flag in his history, but because it was on the schedule. The stress test came back with a small irregularity. That irregularity triggered an echocardiogram. The echo flagged something that needed clarification. Gerald was referred to a cardiologist who ordered a nuclear stress test. That test also showed an ambiguous finding. And at the end of that chain, Gerald ended up in a procedure room for a cardiac catheterization, an invasive procedure that requires inserting a catheter into a major artery to get a direct look at the heart. During that procedure, there was a complication, a small arterial injury. Gerald spent 5 days in the hospital recovering, and when everything was reviewed, there was no evidence of a clinically meaningful heart problem to begin with. The original stress test had almost certainly flagged a false positive, which is not a failure of the test itself. It is a statistical reality of using a sensitive test in a population where false positives are common. But a false positive at 73, in a system that defaults to escalation, does not get noted and set aside the way it might at 45. It becomes a cascade. Gerald told me, sitting in my office weeks after his hospital stay, that he had walked into that first appointment feeling better than he had in years. He said he left with damage that had not been there before, and questions that were still not fully answered. If you have no cardiac symptoms, no history of heart disease, no elevated risk factors, and your doctor is ordering a routine annual EKG or stress test, you are entitled to ask one direct question before you say yes. Is there a specific clinical reason this is being ordered for me, or is this a routine screening? That question will either produce a real answer that gives you confidence in the test, or it will open a conversation that was always supposed to happen. Either way, you win. The reason over-testing is so persistent in older adults is something I want to explain carefully, because understanding it will change how you read everything that happens in a medical appointment from here on out. There is a structural reality in medicine right now where ordering a test creates documentation. It creates a paper trail that says, "We looked." In a liability-conscious system, more documentation often means less legal exposure for the physician. This is not cynical. Most doctors are not thinking, "Let me protect myself," when they hand you a referral. But the system around them is built in a way that defaults to ordering rather than not ordering, and the burden of slowing that down falls on the patient to ask questions. The guidelines have moved. The science on many of these screenings for older adults has shifted significantly in the last decade. But the ordering habits of a busy practice do not always move at the same speed as the research. Your questions are what bridges that gap. Now let me tell you about something that affects an enormous number of women over 65 and causes a specific kind of harm that almost nobody talks about openly. The anxiety is the harm, not a future disease, not a misdiagnosis. The anxiety itself, triggered by a test result that was never a real threat, is a genuine medical event with measurable physical consequences. Routine cervical cancer screening, the standard pap smear, has a clearly defined stopping point in the guidelines. For women over 65 who have had at least 3 consecutive normal results or 2 consecutive normal co-tests within the last 10 years, continuing to screen adds no protective benefit. New cervical cancer development in that population is exceptionally rare. But abnormal results still happen because tests are imperfect, because lab artifacts exist, because tissue changes with age in ways that can look like something they are not. A woman I will call Patricia, 67, a retired librarian from the Pacific Northwest, had been going to her gynecologist for over 30 years with a spotless screening history. At her annual visit, her pap came back with an abnormal cell finding. She spent 11 days waiting for her follow-up appointment. She could not sleep. She had gone online, which almost always makes things worse, and had convinced herself she was looking at a serious diagnosis. When her follow-up test came back completely normal, and the original result was categorized as almost certainly a lab artifact, she sat in the exam room and cried, not from relief, but from exhaustion. She said those 11 days were some of the worst of her life, and they were entirely preventable, because she should not have been screened at all based on her history. If you are over 65 with a long, clean screening record, ask your gynecologist directly whether your history meets the criteria for discontinuing cervical screening. It is a reasonable question, and a good doctor will engage with it seriously. Let me give you a concept now that is going to change how you think about every single thing you have heard so far, and every test you will ever be offered in the future. It is called lead time bias, and once you understand it, you will never look at early detection the same way again. Lead time bias means that finding a condition earlier does not automatically translate to living longer. What it sometimes means is that you spend more years knowing about a condition that was never going to change your outcome. You receive a diagnosis at 71 instead of 78, but you die at the same age either way. The only difference is 7 additional years of worry, medication, monitoring, and defining yourself as a patient. For aggressive, fast-moving conditions, early detection is genuinely life-saving. For slow-moving, age-associated findings, which is the category that catches most older adults in unnecessary treatment, early detection can extend the experience of being sick without extending the experience of being alive. This is not a theory. This is why the guidelines exist. This is why major medical bodies explicitly recommend against routine screening for certain conditions in older adults with specific health profiles. Not because those conditions are not real, but because finding them early in that population does not change the outcome, and the process of finding them carries its own set of harms. Consider what happens with bone density screening. A DEXA scan is a genuinely important tool. Severe osteoporosis in older adults is a serious condition, and identifying it early prevents fractures that become life-threatening. Nobody is disputing that. The problem arises when a scan comes back showing osteopenia, which is moderate bone thinning, and that result drives a prescription for medications that carry significant risks of their own. Osteopenia is not a disease. It is a nearly universal biological process in aging adults. The bones lose some density. That is what bones do after a certain age. But when a scan flags it, many practices respond with a prescription for bisphosphonate medications, and what often does not happen in that appointment is a full explanation of what those medications can do. Esophageal irritation is common. There is a rare but serious condition affecting the jaw. And there is a documented paradoxical effect where long-term use of a drug designed to prevent fractures can actually cause a rare and severe fracture of the thigh bone. Before accepting a prescription based on a bone density result, ask your doctor to calculate your FRAX score, which is a tool that estimates your actual 10-year fracture risk, using multiple factors beyond just the scan number. Ask specifically, what is my actual fracture risk, not just my T-score? That question transforms the conversation from a single number on a printout into a real clinical picture of your individual situation. There is one more screening I need to cover, and it is the one that generates the most fear and therefore the least questioning, which is exactly why I want you to hear this clearly before your next appointment. Routine PSA testing for prostate cancer in men over 70 is explicitly discouraged by the same preventive medicine task force that sets national guidelines on screening. The reason is precise and important. Prostate cancer in older men is often slow-growing, to the point where a man will die with it rather than from it. His heart or his lungs will give out long before that cancer ever produces a single symptom. But PSA testing is sensitive, and it finds those cancers. And once a cancer is found, the pressure to treat it is enormous, even when the clinical picture suggests treatment may cause more harm than the cancer ever would. The treatment pipeline for prostate cancer, biopsy, then often surgery or radiation, carries permanent side effects that are not minor. Incontinence and sexual dysfunction are life-altering outcomes, and they follow men for the rest of their lives after treatment. If those side effects follow treatment for a cancer that was never going to cause harm, then the test that started the chain created the problem. That is not a risk that comes from doing nothing. That is a risk that comes from a test. If you or someone you love has been through that experience, if a PSA result led to a biopsy and treatment, and side effects that changed daily life, and you later learned or wondered whether that cancer was ever truly dangerous, you are not alone, and your experience matters. To other people who are sitting right now with an elevated test result and no idea what to do next, I want to leave you with 3 questions, because information without action stays information and does not protect you. Write these down. First, is this screening still recommended for someone my specific age and health history? Second, if this test comes back with something unusual, what happens next, and what does that entire chain of events look like? Third, is there a less invasive option that gives you the same clinical information? Those 3 questions will do more for your health than any piece of paper your doctor could hand you, because they force a conversation that the system was not designed to start on your behalf. You are not fighting your doctor when you ask them. You are doing exactly what a prepared, informed patient is supposed to do. The doctors who are worth your trust will welcome those questions. They will slow down. They will explain. They will build a plan that actually fits you, your history, your values, your risk tolerance, and your life. That is the kind of care everyone over 65 deserves, and it starts the moment you walk in, with those questions already written on a piece of paper in your pocket. If there is someone in your life, a parent, a sibling, a spouse, a friend who still handles their own appointments and has never heard any of this, share this with them before their next visit. Not because something is wrong, because they deserve to walk into that room knowing what to ask. And if you want to keep having this kind of honest, specific, research-based conversation about what happens to the body after 60 and what the medical system is not always telling you, the next thing I am covering is a finding that affects a large portion of adults already on blood pressure medication. A little-known rebound effect that causes some people's blood pressure to actually rise because of the pill they are taking to lower it, and why the time of day you take your medication may matter more than which medication you are on. If you are managing blood pressure, that conversation is for you, and you will want to be there for it.